This program is part of ANCOR's 2020 annual conference, one of many opportunities offered to ANCOR members throughout the year. ANCOR is the American network of community options and resources. Learn more about ANCOR and explore membership benefits and options at anchor.org. We hope you enjoy today's session.
Hi, and good afternoon, everyone. My name is Gabrielle Sedor, ANCOR's Chief Operating Officer. We're glad that you are joining us for the session on Medicaid 201 today. We've got over 375 of you here with us today. But before we begin, we wanted to share just a few housekeeping reminders. Closed captioning is available for this session. To view the caption, select Closed Caption from your Zoom control panel. Please use the Q&A feature to send questions for the presenter. We'll address questions at the end of the formal presentation. The video recording and slides from this session will be made available after the event. Stay tuned for the announcement from ANCOR when the files are available. And now I'm delighted to introduce to you two of my favorite colleagues, Donna Martin and Sarah Meek. Donna Martin has worked in the field providing supports and services to people with developmental disabilities for over 30 years. She began as a weekend DSP while in college, and over time, she's held positions at every level of service provision. Prior to joining ANCOR, Donna served as the Executive Director of Community Provider Network of Rhode Island, an association of 22 member agencies that provide supports and services to children and adults with developmental disabilities. Sarah Meek oversees all of ANCOR's federal advocacy and manages relationships with Capitol Hill. Prior to joining ANCOR, Sarah served as the Director of Public Policy and Advocacy for Lutheran Services in America, Disability Networks, a nationwide association of Lutheran social ministry organizations serving the needs of people with IDD. If she's able, Shannon McCracken is also going to be joining us, but fortunately she is advocating for all of us with Health and Human Services this afternoon as we're presenting this session. So without further ado, please let me introduce to you both Donna Martin and Sarah Meek.
Hi, everyone. Thank you so much for joining us today. Welcome to my kitchen. This is Sarah Meek, and I'm excited to present to you today Medicaid 201. So I'm going to do a little bit of setting the stage around the history of Medicaid and how we got to where we are now, because this is not necessarily what Medicaid was originally designed to be. So the evolution of Medicaid was part of the LBJ War on Poverty in the 60s. So it was established in 1965 as part of the Social Security Act. And it was really just tied to the eligibility of what we call welfare or social supplemental security income. So it was a very narrow in scope program that was only tied to your need for other cash assistance benefits that the federal government provided. And honestly, much like the Medicaid expansion, Medicaid was always optional. It was an optional state program. So actually, the last state, Arizona, to adopt Medicaid didn't adopt it until about the 1980s. So not every state had Medicaid starting in 1965. In 1971, Congress looked more at what was happening and which populations were needing cash assistance and being served under Medicaid, and began to understand that people with intellectual and developmental disabilities were making up a huge portion of the folks on Medicaid, and that the services that they needed were somewhat different than the traditional nursing home population, as well as other folks on cash assistance. So in 1971, the 1905D part of the Social Security Act was created, and that's what created our current ICF system. So it made funding available for what it was called institutions in the code, and the purpose of that was to really keep people healthy and safe under the original DD Act, or under the original Social Security Act. So then in 1972, Medicaid was expanded, and it really came to include sort of the traditional poor that we think of now in Medicaid. So it began to include parents and children, and people who had a low income, people who are blind, and other people with disabilities. So really starting in 72, it started to look a lot more like where we are now. So that's where the Medicaid buy-in began. And states could also provide coverage above the income caps for cash assistance. So it really decoupled Medicaid eligibility from whatever the cap was for some sort of welfare payment, like TANF or AFDC, which was the original welfare program. So next slide. So it continued to evolve. So pretty much in the 80s, you know, we had Medicaid as we were. In 1996, the CHIP program was enacted. So that is not officially a part of Medicaid. It is a separate attached program, but they are operated very much in sync. And in 1997, the coverage for low-income children above the cutoff for Medicaid with an enhanced federal match was put into effect. So how did we get our waiver program that we have now? Well, in 1981, Congress created the home and community-based waivers. And basically, what this did is the HCBS program, as we know it now, waived certain requirements that a person needed in an ICF IDD program. So the purpose of this was to provide people the same things that we provide now. There was more of an increased understanding that people wanted to live their lives in the community with their families and other loved ones, and self-direct services. So this is when the 1915 and the 1115 waivers were created, and those are still the most common waivers, really 1915 being the workhorse HCBS waiver, and 1115 being the demonstration waiver where states can try out new programs. Next slide, please. So how did we get all of this? So in 1982, that's the first waiver. It was established by President Reagan, and it's called the Katie Beckett waiver. And Katie Beckett was a woman with a disability who was living in an ICF and just wanted to come home and live with her family. And her parents really fought for her quite a bit, and she ended up being able to live with her family and did die shortly. Not too shortly afterwards, but has passed away at this point. But President Reagan enacted the Katie Beckett waiver. And in 2010, we see that the ACA expanded Medicaid to non-elderly adults up to 138% of the poverty line. So really, we had the waivers, we had CHIP, and then nothing really happened until 2010 to really change the Medicaid program under the ACA, which allowed for the expansion. So this, originally the expansion was supposed to be mandatory in the ACA. It was taken to the Supreme Court by the states and ruled that it could be an option for states. So much like the original Medicaid program, the ACA the Medicaid expansion has slowly been taken up by states, and we're seeing honestly a somewhat similar pattern to what we saw with the original Medicaid program, where people continue to slowly take up the ACA Medicaid expansion. So currently, all but 14 states have elected to expand Medicaid at this point. And we continue, are projecting maybe during this pandemic and the subsequent economic aftershocks that perhaps more states will begin taking up the expansion who have not. So next slide. So Medicaid, sort of as we talk through, Medicaid has really evolved over time to meet the needs of the folks who participate in the program. Medicaid was not, when Medicaid was created in 1965, LBJ probably would not recognize the program where we have now. And so in many ways, it's been a really unique and flexible program to be able to adapt to the needs and how our society changes, how best practices and other things that folks with disabilities, older adults, people receiving income assistance need. that it's really changed and been able to morph into these different waivers. So as you see, originally enacted, and this is the orange line shows you participation in the Medicaid program, and it really starting in the 90s has grown very rapidly. And so you see the Katie Beckett option. You see that women and children now become eligible. And then you see in the mid-90s, 1115 waivers came about, and that Medicaid began to not equal welfare, so that Medicaid was not tied to your eligibility for assistance under TANF or AFDC, but it became tied to sort of level of need, level of care, activities of daily living, as well as some other things. And what's neat, you'll see, is that the Katie Beckett option in 1982 actually really preceded the Olmstead decision by about 15 years. So, so Olmstead, Katie Beckett was really sort of on the forefront of service provision. And then, as you see, ACA, with the ACA and Medicaid expansion, we've just continued to see a big growth in the Medicaid population. Next slide.
Okay, thanks, Sarah. I'll take it for the next few slides. So while Sarah has laid the groundwork for the evolution of Medicaid, we are today seeing a real dramatic uptick in states requesting emergency waivers in response to COVID-19. So there are four avenues with which states can request these changes. Every state, in order to participate in Medicaid, has what's called a state plan, and within that, they outline how they will participate in Medicaid, and they identify the groups that will be covered, what services will be offered above the mandatory services. So in response to the coronavirus, 16 states have applied for modifications to their actual state plan. That's primarily addressing access and coverage issues. And what we're seeing is that there is considerable variation across the states that are applying for the state plan amendments. And that can, as I said, really range from numbers of people to elements of coverage and to different populations. One way that states can submit for an emergency waiver is through the 1115 process. Now, the 1115, as you know, is generally considered a demonstration waiver. They are generally very broad, unlike the 1915 series that focus on particular elements that are being requested. The 1915s really give states dramatic reach in how they want to structure their Medicaid program. At this point in time, just the state of Washington has used the 1115 as a vehicle for dealing with this emergency. The other place that the 1115s can be used is in states who operate their Medicaid program through either the 1915 I's or K's. And it is in those programs that the state plan is used to define the flexibilities in the long-term supports and services arena. Let's see, an element within the 1115s is that states must complete a self-attestation of resources, or excuse me, participants must complete a self-attestation of resources. Typically, as people apply for Medicaid, they have to undergo a financial eligibility determination. And during this emergency waiver, the state is looking at this self-attestation process. Oftentimes, the 1115s will waive budget neutrality. They will enable the state to pay higher rates or retainer payments. They oftentimes will waive the public comment period for changes. They'll modify eligibility, and The one glitch or the one point of accountability that the state has via the 1115 is that they have to complete monitoring of the program within 1 year after the waiver ends. So another real broad use of emergency waivers is with the 1135 waiver. And at this point in time, all states have submitted a request and have been authorized for an 1135. And essentially what these do is modify some of the access provisions to Medicare, Medicaid, and CHIP. And so frequently what we're seeing is that the states are suspending their fee-for-service prior authorizations for care. They are requesting expedited, the authority to expedite appeals processes. Typically there's a 90-day window and then a 120-day window. And the states are asking that they be able to, that people who are denied coverage for some reason be able to submit for an expedited appeals. And the 1135s are also waiving the requirements around public notice. So many of you, I'm sure, have experienced as your states have applied for new waivers over time. There is an extensive public notification period. There's a public comment period. The state is then supposed to take those public comments and incorporate them into revisions or addendums to the plans. Under the 1135 in this emergency waiver process, the states are able to waive that public notice process. And then, much like Sarah referenced the 1915Cs being really the workhorse of the Medicaid program as it pertains to our sector, long-term supports and services, you could parallel that with the Appendix Ks really being the workhorse during this time of states seeking emergency waivers. And what the Appendix Ks do is really allow the state to, in very specific ways, modify their plans. So it is within the Appendix Ks that states can modify or suspend service planning requirements of the 1950s. They can modify service delivery requirements. Many states are asking for caps, to eliminate the caps in enrollment. They can adopt policies to support providers, such as issuing enhanced rates for providers during an emergency period, or requesting retainer payments for programs that have either been shuttered or for which utilization is down. Some of the trends that we are seeing now in the waivers include, under the Appendix K, there are 34 states that have submitted Appendix Ks. 26 of the 34 have requested enhanced rates for providers. But a couple of things to keep in mind about that is that while many states have requested these enhanced rates, there's oftentimes vague language around what those rate enhancements include. Is it a percent of utilization? Is it a percent of the actual rate that is being added? And then even if the state does receive the authorization from CMS to provide these enhanced rates or retainer payments or some regulatory flexibility, they're not necessarily compelled to do so. So one of the things that we are working on here at ANCOR in partnership with our state associations is really trying to hone in on that specific component. Just because the state has requested and has received authorization for these flexibilities, it doesn't necessarily mean that they're implementing them. And that really is where the rubber meets the road. And a few states are only offering rate enhancements on services that have been reduced or closed, such as day services. So while the state says, yeah, we've got this provision in our Appendix K, isn't this a great thing? Well, if you're tying that rate enhancement to a program that is being dramatically underutilized, then those funds aren't really available to the service organization that needs them. So that's something to keep in mind with regard to the Appendix Ks. What I want to do at this point is to spend a few minutes talking with you some more about what some of the key provisions are that we're seeing, what some of the trends are. So with regard to retainer payments, 25 of the 34 states that have submitted Appendix Ks to date have requested and been granted this option. There's a lot of variability that we see across the states' requests here. Some of the retainer payments are based on the actual loss of attendance. So it might be based on a percentage of a prior month's utilization or a prior year's utilization. Some of the states are suggesting that they will enable these retainer payments, but they're only available when an individual served is quarantined. So for example, you may have a residential setting or a community-based setting that's seeking a retainer solution, and they can only access it if someone they serve is quarantined. Some of the retainer payments are going directly to enhanced DSP wages, which is great, but again is very narrow and very specific. Some of the retainer payments only address absences above a standard vacancy rate that may be already factored into a provider's cost, and they are applied to services that provide personal care. So again, 25 states, half the states offering retainer payments with a lot of these provisions is not as necessarily as helpful as we would hope it to be. Some of the other key trends with regard to telehealth, all of the states have applied for and been granted the telehealth option through the 1135 application, again, because that is broader than our 1915C and the Medicaid LTSS, the 1135 waivers reach into the Medicare and CHIP programs as well. So the good news, the really good news, is that the telehealth option has been requested and obtained by all 50 states. And the states are applying it pretty, this element I think is fairly consistent. They're generally being applied across case management, service coordination services. Telehealth is being used for assessments, for ABA and behavior management therapies. They're being used for other therapies like speech, OT, PT. And one thing that I found really interesting was that some states are using telehealth for group therapy services. So I think that's really an encouraging component. A few other key areas, 23 states have requested the ability to temporarily exceed service limits. And I think that hits particularly in states where the individual budget is based around the assumption that they would use a certain number of units in a given month or quarter or other period. And this suggests that the provider can in fact provide greater service. So if a person lives in a residence, the day program is closed, now the residential program is open, it has the person actively with them 24 hours a day, that would exceed the unit of service. And so now this enables them to hopefully bill for that service. 15 states have authorized payment to family caregivers. That is a real pretty unique component. Most states, to my knowledge, do not enable that on a regular basis, but 15 states are incorporating it here for the crisis. 15 states in their waiver have incorporated increased pay rates for staff. 20 states have incorporated the ability to bill for DSP time for hospital stays. We'll talk in a few minutes about Marjorie and Isaiah's law. Sarah will give you some information about that, but that is a piece of advocacy that ANCOR had been working really hard on that got included in the CARES Act. And we see that 20 states are creating a pathway for providers to be able to take advantage of that. And then I just wanted to highlight in this component a few of the key states and what I think is happening there. So Colorado, I think, is the state that has generally speaking, requested the greatest amount of flexibility. They have requested 17 out of the 20 available provisions within the Appendix K waivers. They're followed by Maryland and Utah with having requested 15 of the 20 provisions for flexibility. And then Alaska, Connecticut, Delaware, Nebraska, and Washington all come in with 14 provisions. Again, what I would urge you to remember is that even though a state has gotten the approval from CMS for these provisions, they may not necessarily be implementing them yet. And so that's an element we're going to talk a little bit more later on with regard to advocacy steps. And then lastly, the states requesting the least number of flexibilities include Arizona, Rhode Island, and Virginia. And two elements that I think are particularly interesting here is that Arizona and Rhode Island are two of the three states that operate their entire Medicaid program under an 1115. So those are just some of the trends that we're seeing emerge. And what I'd like to do now is kick it back to Sarah, and she's going to talk about some of the Medicaid components within the COVID relief packages.
Hello again, everyone. So if you're following at home, we've had 3.5 COVID relief packages at this point. So the first package, gosh, it happened in mid to late February, was a pretty small, about $8 billion worth. And it was really some small business loans and gave some emergency telehealth authority in Medicaid. So that was pretty minimally helpful. The second package, was followed quick on the heels of the first package. And many of you may remember it did give an emergency FMAP bump increase by 6.2%. That is obviously way below what governors have been asking for, which is actually about 12%. It also increased Medicaid allotments for the territories, because the territories, as many of you may know, actually receive block grants for Medicaid. They don't receive a traditional FMAP like the states. It also gave emergency paid sick leave, expanded some of the provisions of the Family and Medical Leave Act, and gave refundable tax credits to employers for paid sick leave. So some things for Medicaid, but really not a ton. The third package, we did finally start to see some more bigger things that would impact Medicaid and ANCOR members. So first of all, the small business disaster loans, which I know many of you all have taken advantage of, were created, which gave forgivable loans to businesses and nonprofits with less than 500 employees to really cover payroll, other things like that during this time. It made Margie and Isaiah's law permanent, which was ANCOR's bill that came out pre all of this COVID, but it allows states to make DSPs accompanying the person they're supporting to the hospital under both 1915 and 1115 waivers. So previously to that, you could only get reimbursement for if a DSP supported someone in the hospital that was on a waiver. You could only get reimbursement in 1915 I and K, which is that's like the community first choice option. But now in all 1915 and all 1115 waivers, and this is a permanent authority. So states should be putting out guidance on how this can be applied in your state. But this will last forever now, which is a really cool improvement into the Medicaid program. MFP, the Money Follows the Person program, was also extended for 5 more months to help with transitions of people who are living currently in congregate settings but wanted to move out of those settings due to the COVID virus. There are also some emergency funds that came through the Administration for Community Living. However, those are really focused more on the Centers for Independent Living, senior nutrition programs, which a lot of people with disabilities do take advantage of, as well as older adult HCBS services. The coronavirus relief fund, there's 150 billion there. That's relief directly to states and local governments. So states and localities can apply for that to aid with their coronavirus relief. The Public Health and Social Services Safety Fund, that is a $100 billion fund that HHS, the Department of Health and Human Services, has been sort of doling out. Currently, Medicaid providers have not seen any of these funds. There's some discussion about the mechanism of how you deliver those funds, because the funds have to be paid directly to the provider of services. So Medicare providers have a direct relationship with the federal government, as Medicaid providers really have a direct relationship with the state because of how the programs are different. So currently, about 70 billion of that initial 100 billion has been doled out. ANCOR is fighting really hard to make sure that, and that's actually where Shannon is right now, to make sure that our members can get access to some of the 30 billion that are left. So we are hoping to hear about the next disbursement of this money next week. But we will be keeping you posted. We'll be asking for your action, your contacting members of Congress. And then in the 3.5 is what we're calling sort of this mini package that was passed last week. Congress actually authorized an additional 75 billion for this fund. So, you know, we are working to get you in this last 30 billion, and we are working to get you in the next 75 billion. But please, please feel free to contact your member of Congress. And then finally, you can see there's a few other things in the third CARES package, but it also included the Medicaid expansion population in the folks that you can use the Public Health and Social Services Safety Net Fund money to support. Originally, that was looked at as just the traditional Medicaid population, but this allowed it to expand to that population. Next slide.
Oops, okay. So we had organized this presentation and thinking about Medicaid yesterday, today, and tomorrow. So Sarah kicked us off with a review of how we got here, what Medicaid looked like yesterday. Then between congressional action and state action, we've been talking about what Medicaid looks like today. And now we want to spend a little time talking about what Medicaid may look like tomorrow. So in this section, I'm going to spend a few minutes talking about some of the emerging trends that we've been seeing over the last few years. And since the Affordable Care Act was implemented passed in 2010 and implemented thereafter, there's been a movement away from fee-for-service payment to value-based or alternative payment methods. And some of the alternative payment methods that we're going to review today include pay for performance, managed long-term supports and services, integrated care, and then finally block grants. So with regard to the alternative payment methodology framework, most of our services today fall into fee-for-service or the Category 1 segment as it shows on your screen. So within the fee-for-service construct, there is no link to quality or value as it pertains to payment rates or provider funding. Category 2 is emerging as states try to link quality to payment. These are generally built on top of a fee-for-service framework, but that means they can be really clunky and difficult to access. Oftentimes with some of the funding being so-called left on the table. And that's because they're often tied to the achievement of certain goals or outcomes or increased numbers of activities. So one example or one thing that I'd share is that we more frequently see this link, fee-for-service linked quality or value in the behavioral health sector. Oftentimes states are now starting to try to link outcomes to avoid hospitalizations or to avoid rehospitalization and are looking at measuring post-discharge care and that sort of thing. Oftentimes, these programs are structured as a target goal or a bar the provider has to reach in order to receive an enhanced payment. So for example, a state may contract with a provider for, say, an extra $25,000 in their contract if they see a certain metric. So for example, it may say the state may be requiring that 95% of participants are seen within 48 hours from discharge from a hospital or rehab. That might be a metric that is built in. It sounds great, you know, you're getting this extra funding for basically doing what you do anyway, but what if the provider only hits 94% of the participants discharged? It becomes an all or nothing proposition. So one of the things that providers are looking at now and starting to push back with the states on is recommendations for more of a sliding scale. And so this is, I think, a structure that is evolving and will change more over time as we sort of find our equilibrium with it. And it's difficult too because oftentimes these metrics are tied to health-related outcomes, things that are really quantifiable, countable, and you can see where that differs from our work. And it is harder to measure, for example, quality of life or community connectedness or social relationships. And that's the work that we tend to do in IDD and autism long-term supports and services. Part of the struggle that we face in sort of coming along with this initiative is that our sector has been slow to adopt a universal set of quality measures. But there are a number of projects that are trying to tackle this. For example, ANCOR is involved with an initiative that's being co-led by CQL, provider organization Mosaic, and the Institute for Public Policy for People with Disabilities in Illinois. We have been working with that group as they are trying to define and refine what are some of the quality metrics that fit within our service sector. Additionally, CMS is set to release an RFI on their proposed voluntary quality measures set for long-term supports and services. So the other thing that I wanted to note here with regard to the alternative payment framework is if you look at it, you need to think about it as a bit of a continuum, right? So in category 1, there is low risk, it's fee for service, and you get paid for what you provide, regardless of the rates. That's a different conversation, but you get paid for what you provide. There's low incentive, and there's low risk. But as you move through the continuum, the risk and incentive balance shifts. So as you look to category 4, where you have population-based payments that may either be population-based around a health condition or around a sector of some other definition of a sector of Medicaid participants. And the more risk that an association is able to bear, typically the greater the proposed enhancements are. So the next sort of trend that we see in, aligning my slides here, the next trend that we see beyond pay for performance or value-based purchasing is with regard to managed long-term supports and services. Now, since the outset of the ACA and that program's desire to incentivize value rather than volume, many states have moved their healthcare systems into managed, like a managed care paradigm. And oftentimes states will report that they offer a managed long-term support and service program. What we find, however, is that those managed LTSS services tend most frequently to be within the senior care or the behavioral health care arena. And there are only a handful of states that have managed long-term supports and services in our sector. So you can see on the screen the MLTSS approvals. There's 20 some odd states that offer it, but that is outside of, in many cases, outside of the IDD sector. Within our sector, within the IDD population, this MLTSS initiative is included under a number of different authorities. So Arizona is probably one of the longest standing programs of this nature. Iowa and Kansas, as you know, both entered into managed care with everything all in a few years back. Both have had very challenging experiences with that transition for a number of reasons. And certainly I know Iowa continues to struggle with provider payments and continuity of MCOs. Michigan has a managed specialty support and service program. North Carolina, interestingly enough, has had managed LTSS for their community-based services for many years and not on their healthcare delivery side. And they were set to launch the healthcare managed care half of that arrangement this year, but for a number of budgetary reasons, it's been postponed. New York State has had their fully integrated duals advantage, and they have been poised to really launch that program. But again, this year, a new commissioner seemed to have put the brakes on a bit and is rethinking some of the initial plans. In Pennsylvania, we have the Adult Community Autism Program, which is an interesting sort of alternative to managed LTSS as we typically think of it. It is organized and administered by a service provider organization, and in many ways looks similar to the PACE model, which I'm sure many of you are familiar with. And then Tennessee has its Employment and Community First Choices waiver, and Wisconsin has also, for a number of years, had managed LTSS in their healthcare and IDD services in a limited way. They limited theirs geographically and have slowly been expanding across the state. This data was provided by a Truvid report from 2017, so there may have been some updates since, one of which I can tell you about is Arkansas. They have been developing a managed LTSS program that is provider owned and it works in partnership with the MCO. So those are two of the trends that are forthcoming that we'll continue to see more of once we move out of this emergency phase in our history. The third initiative is with regard to integrated care. And again, that is in many ways like a PACE model. Certainly it's not line for line, but they are similar. They have a lot of parallels in that it is an attempt to, under one authority, integrate all aspects of the person's care. And this image comes from the UConn School of Nursing, and it represents their geriatric outreach and training with care interprofessional practice model. So I'm borrowing something that is from not an IDD sector, but I thought it was a really good visual to depict the notion of integrated care for people with IDD. And it's really focused on linking and coordinating the services and supports from, that are around the whole person. I especially like this model because it depicts the family, caregiver, and community support components at the center of the model, but they are integrated and linked to healthcare therapies and pharmacy service. And then lastly, the fourth trend that we're really watching is with regard to Medicaid block grants. So generally, CMS is interested in block grants as a way to cap the Medicaid expenditures. And some states are interested because the grants suggest greater flexibility for the state. Through these grants, states can modify their covered populations, they can modify covered services, they can change the Medicaid drug formularies. There's a lot of tweaking that states can do, and the trade-off is that the amount of money is capped. The state no longer has the FMAP variability as their population and spending per capita changes. At this point in time, Tennessee has drafted an 1115 proposal for a modified Medicaid block grant, and their provisions, there are 4 core provisions of their proposal that vary from the standard grant. Theirs has a base share plus a Congressional Budget Office projection for annual growth. That's different from a typical Medicaid block grant. They are not adjusted annually. Tennessee is also requesting an adjustment to the cap of enrollment if enrollment exceeds the base projections. The third component is the maintenance of effort is based on 2019 spending and trended forward. And the state can use their funds for non-Medicaid programs, which is unique. And the fourth component that's really interesting is that the state, if this is authorized, would be eligible to keep 50% of any of the savings accrued between where the cap is set and what they actually spent. So for example, if the Medicaid budget was set at $1 million and the state only spent 800,000, they would be eligible to keep half of the $200,000 savings. So that's a really unique proposal. It's the first one really out of the gate since this administration has been promoting block grants, and it'll be interesting to see where that comes in. And then most recently, Oklahoma has submitted their proposal, which also includes some interesting components around premiums and cost share for participants. They build in a work requirement to their plan as well, and some other provisions. So that's sort of a high-level overview of where we think Medicaid is going and what we're likely to see tomorrow. So then just to start to wrap up, I wanted to ask Sarah if she can talk about what are some of the action steps you can take today with regard to advocating for Medicaid.
Thanks, Donna. So we really need your action, everybody. And Donna, if you could move it to the next slide, that would be great.
Oh, yep. I'm sorry. I'm
It's okay. So currently, we sort of have a two-pronged approach. So right now, our action is really focused on getting some of that $100 billion and then the next $75 billion from the Public Health and Social Services Safety Fund. So we are currently advocating with our congressional delegation around reaching out to the Department of Health and Human Services to make sure that Medicaid funded providers are a part of these services. We are meeting with HHS as we speak to talk about this. So we would love for you all to reach out to your member of Congress, reach out to HHS, to your state, and ask them to include Medicaid funded service providers in any disbursements of this critical fund. So that is really the first thing that's not a legislative ask, but is the most immediate thing that you can do. And then in the next, there will be a COVID-4 package. We just heard from Politico that the Senate is expecting to return next week. That will probably begin the start of looking at a COVID-4 package. So looking at specific funding in the fourth COVID package then to support direct support professionals and stabilize that workforce, as you all know. So for things like overtime, stabilization pay, those kinds of things, that's what we're really looking for. And then finally, you can look at what we need.
Oh, I think Sarah froze.
Sorry, my computer malfunctioned for a minute. And then in tomorrow, also looking at what's going on in your emergency waivers through your K waivers that could result in improvements. What's working? What flexibilities do you have? And how can we build on those after, we are all thankfully allowed out of our houses? And how can we build on those to improve the disability service system in the future, and looking at the new payment models and how they are working, and how you can work with your state and how we can all work together to get these improvements that we're seeing that create better outcomes, better quality of life for people with disabilities, and also more streamlined processes for providers and states and the federal government. How can we work to get those implemented as to permanent policy in the future?
And I actually just wanted to go back to this graphic because this was my Medicaid block grant slide that I really liked. And I didn't advance it, so I just thought I'd share it with you all. But to Sarah's point, I think it's really important that you stay engaged in the conversation around what your state is doing, you know, looking ahead to Medicaid. You really should be at the table if your state is starting to think about implementing anything from a value-based payment to managed LTSS to even a block grant, because those funding changes will have a dramatic effect on how you implement and provide the service that you do. So it's really important that you stay engaged and be a part of that conversation. There you have it.
Great. So Donna and Sarah, if you're open to it, we do have a handful of questions. If you would like to try to answer some of them.
Sure.
Fantastic. So let's start with not a question, but a comment. And I think you guys will like this one. As someone who's been around ANCOR for the last 30 years, I and others stand in awe at how hard the government affairs staff has been working on our behalf. You guys have moved issues to the center of the debate, which is no small task with all of the demands of all advocacy groups at this time.
Well, thank you. I promise that's not my mother, but thank you. I appreciate it. I know Donna and I and Doris and Shannon, we really appreciate and appreciate all y'all are doing for people with disabilities at this time.
Yes, let me add that your grassroots impact can't be underestimated. So the answer is yes, we will be sharing the slides and a recording of today's presentation. So within those slides, you'll see the list of actions that Sarah and Donna have requested of you. They really are impactful. So we please do ask that you keep reaching out. Another question has to do with access to utilization data about state waiver services. Someone is curious to find out the number of individuals who use self-directed services. They are aware that 1915C waivers have some reports, but there's some question around where to find them. So if either of you have any insight into where utilization data would be easiest to get, that would be helpful.
That can be pretty tricky. I think there is some really high-level utilization data on the CMS website and perhaps on the Kaiser Family Foundation website. That's really a go-to for me when I'm looking for data. Kaiser, I think, does a great job sort of keeping up with changes in state Medicaid programs. I'm not sure that either source really kind of digs deeply enough with the specific program level data you're requesting, though, but it'd be worth checking those two websites.
Here's another question that I'll just repeat just in case others have the same question. The 5-month Money Follows the Person extension will take us through which state? And Sarah kindly responded until September 2020. But then again, that assumes life goes back to normal then. Sarah, I don't know if there's anything else you'd like to add to that.
Yeah,
response.
no. So in a previous iteration of the bill, actually, MFP was extended permanently, which means it still was a demonstration program, but there was just no end date on the demonstration program. However, then the White House got involved, and to be able to get some of the other provisions that were really sorely needed, like the small business loans and things like that, the White House did not want to extend any Medicaid extender. So it wasn't just about MFP, it was about what's called DISH payments, which are payments to safety net hospitals and community health centers and other things like that. They didn't want to extend any of those programs beyond 1 year. So that is how we ended up with the 5 months. And that goes to September 2020. And the thinking then is that there are a bunch of Medicaid programs that need to be extended that would all converge at that point. And so the original thinking is that there would be a Medicaid extension package in September that would then be passed. I mean, I think that was, when we passed the CARES Act, that, I don't know how many weeks, years, it feels like all a blur at this point, but that was, assuming that everything would go back to normal and we would have a regular Medicaid extenders package in September, which I have no idea now if we will.
Great. I think we might have time for perhaps one more question. If anybody has any additional questions, the Q&A component is down there in your Zoom toolbar.
So I see a question regarding when North Carolina will revisit the managed care program. Well, I think that that's still a bit up in the air. At least the last time I read some information about their status. They had the MCOs ready to go, and they ended up having to put a pause on the project, literally weeks before initiating it. So there remains a budget impasse with regard to a couple of provisions that are affecting the initiation of this managed care initiative in North Carolina. And I think until that budget impasse is resolved, this is likely to hold. So I can't imagine it's going to be much before July.
Thank you, Donna. So I think that just about brings us up to the hour. Oh, one more has come in. Has ANCOR looked at the New York State Medicaid redesign recommendations, as well as the status of CDPAP?
We have not specifically worked on that, although I have participated in the development of a white paper with regard to the process around redesigning the Medicaid program in New York State. But again, they are having some significant budget issues that will have a significant impact on their Medicaid program. And so I think that that is again further complicating the issue for them.
Thank you. Last question, and this is probably a pressing one in lots of people's minds. In earlier discussions, there was some discussion of direct payments from the feds to providers. Is that still the likely process through a portal, or do you think providers would have to apply through state agencies?
I don't know. To be honest, I think the first question is even step back is that, is some of this money going to go to Medicaid funded providers? And I believe that's where we're at this point, is just trying to figure out if this money will go to Medicaid funded providers. And then if so, in talking with our, and I see, do you have a crystal ball? I do, definitely. Actually, we are reading Harry Potter at my house. And so I've been very into divination right now. But so I think we've heard from various offices on the Hill that they believe it's clear that the CARES legislation says that the payments would have to go straight to a provider and could not go through the states. So there would have to be some sort of portal or something like that where you could sort of just self-elect into it and provide whatever documents. However, I was talking with my colleague at NASD's, the DD Director Association, on Friday, and he reported that NAMID, which is the Medicaid Directors Association, has been in talks with HHS, and they believe that the simplest way is to give a direct pass-through to the states that would then give it to you guys, you know, with specific directives on what to do around it. So, and they believe that they do have the authority through the CARES Act, that HHS can do it that way. So, you know, we just don't know. I just got off the phone with another office, a Republican House office, before our call, and they said that they were confident that HHS was going to announce that Medicaid providers were going to get some in this next disbursement, but I don't know. So we're pushing hard for that is really my biggest answer. And we'd love to hear from you guys if you know, if there are ways that you think it would be easier. I think, you know, it seems to be that the states are the easiest way to do it just because this is how they do it. So they know how to pay you guys if you do a direct pass through. But, you know, if the only way to do money is to do a portal, then let's do it.
At the end of the day, we just want to ensure that whatever is available gets into your hands into some way, shape, or form. So Donna and Sarah and the full government relations team are working hard to make that happen. Thank you all so much for spending your hour this afternoon with all of us. The information will be shared, will be available. We'll let you know as soon as you'll have the ability to access it. Please don't hesitate to reach to Sarah or Donna with any additional questions that we didn't get to. A very sincere thank you to our closed captioner extraordinaire, Anthony Trujillo. He's been doing a wonderful job here. If you need the transcript from today, we can get that to you as well. So thank you again, and look forward to seeing you all at our next session at our virtual conference. Have a wonderful week.